But I didn't love you, darling.
Welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have an amazing guest tonight. It's my dear friend and colleague, Shannon Blewett. And today is a very special episode because it's the 100th episode of the podcast. So cheers to that, my dear friend.
Congratulations, darling.
Thank
We're so proud of
you.
you.
So cheers to that again.
Cheers to that.
So that's why we kind of want to make it special. And we decided to just do it in my home and with a little bit of drink to celebrate. But I'm going to start with just introduce you, Shannon. She's a physical therapist specialized in oncology at UF Health. She moved to Gainesville in 1994 to attend the University of Florida and graduated with honors with a Bachelor of Health Science in physical therapy. She has been a part of the Cancer Rehab team at UF Health since 2001 and has contributed to the significant growth of the program. She earned her Lymphedema Therapist Certification in 2004. She has spoken at the National Lymphedema Network International Conference, has been a guest lecturer for the University of Florida Doctorate of Physical Therapy program yearly since 2002. She loves to travel, hike, kayak, watch sports, especially the Gators, very big Gator fan, and any activity of time for her family and friends. So Shannon, it is a pleasure to have you with me, and I want you to be my 100th episode because Shannon was the person who inspired me to become an oncology therapist. So I remember when I got the opportunity to start doing some oncology, and I have absolutely no idea what I was getting into it. And I remember coming to shadow you and for a week. And again, I'm coming from a sports medicine and orthopedic background and with no idea about what oncology physical therapy was. And I came to to the clinic and I was like totally in love with it within the first week. So you totally inspired me. And that's why we've been kind of waiting for the 100 episode time to have you on board. So thank you for being here tonight.
Of course.
So what inspired you to specialize in oncology physical therapy?
Okay, so that was just kind of circumstance. And when you think about in life, you think you might have a plan, and then things happen that actually guide you in the way that they're supposed to be. You just didn't know that. So I initially came out of PT school and I did pediatrics. I had even done one of my internships at Arnold Palmer Children's Hospital. It's just what I always wanted to do, is work with children. But when we graduated, it was the second year, I believe, of a Medicare cap that had come about, and the PT market was saturated with therapists. So there were not a lot of jobs, and there were a lot of therapists looking for jobs. And so the new graduates really had a hard time finding jobs in the beginning. So I took a job as a rehab aide, physical therapy license, being a rehab aide. It's a very good thing to do, though, to really understand what an important role that is in the clinic, just so that I could get my foot in the door at Shands. And then when something came open physical therapy wise, I'd be one of the first ones they would look at because I was internal, and the pediatric group let me go and shadow if the clinic was quiet or on my free time. So I was able to still be getting some pediatric experience and observation. And the first job that came open, though, was an inpatient job, but I took it because it was a PT job versus a rehab aid job. And then about 5 or 6 months later, the same group that I was doing the rehab aid work for, which was an outpatient ortho clinic, they had an actual benefited PT line. So I just felt like that was the right thing to do, adulting, to get the benefits and be working as a PT. But in that clinic, I had the opportunity to work with Rosemary Wheeler and Chris Roberts, who were the two therapists that actually started the lymphedema program and the breast cancer program at UF Health Shands. And I just literally fell in love with those patients. And so when a pediatric job did come about, I actually very nicely, but declined because I just wanted to keep learning more and more about oncology and lymphedema.
Excellent story. What do you think? Well, do you think that you ever regret it? Do you think that like it's like, man, I've been doing all these years in oncology. I wish I did something different, and I wish I experienced something different.
No. So that's what's actually cool about physical therapy. And it's what I tell students when they come through, or we talk to volunteers or students that come through thinking of physical therapy, is I think it's such a great career. And the fact that you really can't get bored. There's so many specialties. Unlike, say, med school, you learn your specialty and you're kind of stuck in that specialty. You don't often see, physicians adjust that throughout their career. Whereas with PT, as Darlie has experienced in her journey as a PT, you can love neuro patients and do neuro patients for 10 years and then think, I really want to focus more on geriatrics. I'm going to do that now. And then, like with Darlie, suddenly doing oncology. So that is actually one of the very cool things about our profession. For me, I feel like I just found my passion and love early, and I've just never wanted to do anything but.
That's excellent. And then you can totally tell. So whoever knows, whoever has been following on this podcast that is in our community knows how much passion she has for these patients. And it's totally, absolutely contagious, because that's how we are, right? So this is kind of like, I came into this knowing nothing, absolutely nothing about oncology. And Shannon kind of really like, no, like, this is what we do. And it's like totally just kind of like, got really on the line of manual therapy. That is what I really enjoy doing. And that was just really a little extra. Like I tell the students, it's like oncology therapy is like you doing your orthopedic patient, but with the flavor of some of the cancer treatment secondary effects that you have to kind of learn and know and take in consideration. But really, it's like any other shoulder, any other neck. But I think the patients themselves just have something special about them that is what makes this so fun.
I agree.
It's rewarding. It is, I don't know what it is, but it is just,
like I just can't imagine. See, now that you've been bit by the bug, I mean, a long time now, but you can't imagine treating a different population, right?
No, yeah, absolutely.
They just really are so special.
Yeah, absolutely. So how you kind of share already a little bit about your journey on this field. How do you feel that you've been growing in this field as an oncology therapist?
Yeah, I think in any field in medicine, that is one of the things I also like about medicine is it's always changing. I mean, so much has happened in cancer treatment, not just rehab wise, but the medical intervention since I've been doing this since early 2000. It blows my mind sometimes when I think about in terms of the surgery, how that's changed, the chemo how that's changed, even radiation therapy protocols, the hormone therapy. I mean, it's just, and then we adjust to that because that's our main job, is to help the patients with the side effects from all of that. So I think it's ever changing and growing. So yes, that is also very exciting.
Yep. And again, that kind of make us be in our toes, right? Like,
yeah,
I remember when we used to be by the radiation oncologist, and I remember us going to their meetings, and that was already like a very foreign language for us when they would start talking about, how much was the plan of treatment, how much radiation we're at. And then I kind of like every time it's like a change on protocol, right? We don't do this anymore. Now we do this.
Yeah.
Now it used to be 6 weeks. Now we do 3 weeks. Now we do this every other time, every other day. I mean, it is amazing, which is a good thing, right? So we like, sometimes I love to hear Dr. Spiegel, the breast surgeon that we work with, in her lectures. She really talks about back then, years ago, how we used to take everything, right? The breast and everything. And now it's like, why are we doing that, right? If it's the same survival time. So it's like, do we really need to do that? Now we're doing so much better testing to see that really the patient is going to be beneficial from chemotherapy.
Even the idea of doing the sentinel lymph node biopsy, that was just this. I just remember being in some of those, lectures or conferences, and the surgeons going back and forth a little bit on that. Like, how are we going to convince patients that no, it's okay, we don't need to take all the nodes, or neoadjuvant chemo. What? We're not going to do surgery right away and take the cancer. I don't know if I can do that. The patient's expressing, and then being able to show, no, this is actually going to be a better outcome. So that's all been in the last 20, 25 years. That's what's really cool.
Yeah. It's very great.
Yeah.
What are some of the biggest misconceptions people have about physical therapy in oncology?
Yes. So I think even, very seasoned physical therapists get a little like, cancer patient, just because they think about the patient being, I think anyways, they might think of the patient being very sick, Like, oh my gosh, are they going to be throwing up a lot? Do I have to watch their blood counts? Am I going to be able to do anything with them? I think, as Durley said then as well, for a second point, is they don't recognize that a lot of the side effects truly are things that you are already skilled in as a therapist. You know, you are looking at them orthopedically, you're looking at them if it's a brain tumor patient or a chemotherapy patient that's getting some peripheral neuropathy in the feet, you're looking at them like a neuro patient. You know, there are some subspecialties of what we do, you know, like the lymphedema, being really educated on some of the cancer-related fatigue things. But other than that, it's a patient that you are skilled to see. So I think that scares some, that not scares them, but puts them off from really necessarily wanting to explore being a therapist with oncology patients.
And I'm agree to that.
Don't
You
you
know,
think?
when our students come in, they have absolutely no idea, right? And they really have a lecture maybe in the school about
Like a 1 hour
oncology.
lecture.
Yeah, exactly. And really not that much exposure besides that. And then when they come in into the clinic, it's like, oh my God, like, you know, it's scary, it's intimidating, it's a lot of things that you gotta know.
Yeah.
So the basic skill in regarding how we perform an evaluation and how we do certain treatments are really what you learn usually for any other kind of like musculoskeletal issue. But the fact that you have to take in consideration all these medications, blood counts, like you mentioned, hormone therapy, and what that can be, or hormone blocker, sorry, and what that can be doing. And
or even maybe radiation therapy.
Exactly.
That can seem like, oh, I can work with a patient during radiation therapy. Yes, you can.
Yeah.
You're just going to take some precautions now, you know, at that tissue area that's being radiated, but it doesn't mean you can't still be working on other areas in the upper quadrant. You can't still be working on lymphedema prevention, you know, their fatigue exercise prescription. You know, that can all still happen. They don't have to be an off limits patient. And I think that's what surprises people, that we treat these patients during their cancer treatments.
Exactly, because again, what do we learn in school, right? A lot of things are contraindicated in cancer. So if a lot of things were contraindicated in cancer, we couldn't do anything with these patients, right? So they learn, or we learn a lot, that absolutely everything is about quality of life, right? So certain things, it's not really no evidence based saying MLD is, or manual lymphatic drainage is contraindicated in a stage 4 cancer, right? No, it is no evidence. So if we have somebody with lymphedema stage 4, you know, how are we going to be able to try to improve that? Because that is going to, managing that is going to improve their quality.
Yeah, and stage 4 cancer patients are living years now.
Exactly.
I mean,
exactly.
That's another thing that's changed since I started seeing these patients. That was not the case then, and now it's like, no. Something very interesting, and I should go back and look at who the lecturer was, but I remember she's from the University of Michigan, and it was in the first year or two I was treating cancer patients, and she talked about cancer as a chronic disease, and us as medical professionals to stop looking at that patient and saying, oh, well, you're done with all your cancer treatments, you know, we'll kind of eyeball you till the 5-year, but you know, you're kind of done with us, because all of these interventions can have longer term side effects, we understand now, as well as they are now setting protocols where they're monitoring the patients for any return of cancer longer than they used to. And so looking at them as a chronic patient, I think is a very big deal in terms of the survivorship numbers as well are higher.
Yep.
You know, and so I think that's also been a very big change in the recent years.
Yep, absolutely. How does cancer treatment impact a patient's mobility and overall physical health?
Okay, so with surgery, they lose range of motion at that surgical site in terms of, say, a breast cancer patient could lose range of motion in the shoulder from scar adhesion. Scar can attach to fascial muscle, bone. If they have a loss of range of motion in the shoulder, that's then going to affect the thoracic region, the scapula, the neck. So we're looking at that whole quadrant. Same with any of the other patients. So I had a neck cancer patient, we're looking at the same thing: neck range of motion, jaw range of motion, whole upper quadrant. Those are the two main populations we see, but when we do see anything else, maybe it's like a leg sarcoma, just same scenario. So range of motion can be an issue. Range of motion can also be an issue with radiation therapy. With radiation therapy, though, we're also looking at changes to the tissue, skin integrity during radiation, but then also later down the road, radiation fibrosis, which can also then cause tightening, loss of range of motion, pain. It can result in some swelling in the quadrant. because you're not getting good, you're getting some lymph blockage now. So yes, with radiation, it's range of motion, the skin changes, including radiation fibrosis, the cancer-related fatigue with radiation. So that is something that they will experience throughout radiation, but does not suddenly stop when radiation stops. So that is one of the longer term symptoms that we are working with the patient on. And then you have the chemotherapy, so they could have loss of strength, they could have loss of actual muscle mass, as well as the cancer-related fatigue, peripheral neuropathy, which puts them at risk for balance issues and falls. So we want to be sure that we're on top of that. We can't do anything to stop peripheral neuropathy, but we need to be sure that they have good, ankle and hip mobility, strength in those joints as well, that they're, response to a trip or fall is good. So it just allows us to really monitor that and work on it if needed. And then they go on the hormone therapies where they could lose bone density. And so we need to be, again, really on top of what is their risk factor for falls, be sure that they are strong, they have good balance, and they're doing things to increase skeletal muscle mass and keep the bone density as good as possible. So there's a lot of side effects that can come about from the cancer treatments that we are evaluating and educating the patient on and working with them on.
So what do you think is one of the biggest challenge that patients face when undergoing physical therapy during cancer treatment? You have the patient who comes, or the doctor say you need to go to physical therapy, and they're like, so how do you think, what is the challenging for the patient when they hear the word, okay, I want you to go see physical therapy?
I think the first thing is they all say, why do I need to go to physical therapy? Because no one thinks physical therapy and cancer, go together. So literally when we go and get the patient and we introduce ourselves and we say, we're happy you're here at the clinic with us, the first thing both of us say is, you're probably wondering why your doctor sent you to physical therapy. And then we just literally say, you are going to have side effects from your cancer treatments that we can help with, and that we can educate you on, and we can give you a plan that you can perform at home that will help you with those things. It is our goal to return you back to full function and a good quality of life after all of this cancer treatment journey you're about to go on. That's probably the first challenge, is getting them in the clinic, because they truly are like, what in the world is that all?
Yeah,
Physical therapy.
Yeah, and I think goes more towards like the patient who is about to start radiation. We know surgery, right? So sometimes when they have surgery, usually they know they have some kind of dysfunction, right? Either decreased mobility of the shoulder, the neck, or whatever it is that they did surgery. So these patients are like, yeah, I guess I'm coming because I just have surgery on my neck and I cannot move my neck or my jaw, whatever goes on. Same thing with the breast cancer patient, right? I'm really having a hard time with my arm or the scar or any of those lines.
But I do think with the surgery patients, we are very fortunate to have physicians who support us in a pre-op program, so that we can really take a look at what does that patient look like pre-op, and then we know post-op what was actually related to the surgery. In the pre-op, they are sometimes like, I don't really know why I'm here, which is wonderful that we're able to see them pre-op, because then we can explain how we'll be able to help after that. But yes, especially you were moving in the direction of with radiation or chemo, they really are like, what is PT going to do for me?
Yeah. And then in the beginning, because they're doing well, right? It's the first week of chemo, the first week of radiation. They're like, I really think this is kind of a joke, right? This is a waste of time. This is a lot of the attitude we get. And then it is amazing when we start like explaining to them what we do, how we just want to measure where they are at that point, and for us to try to really see them throughout like the whole treatments. If we find they have some issues, then we'll treat them then. If they don't, we tell them just come maybe in a couple of weeks or halfway through the radiation. And it is amazing. Sometimes, I really remember this guy, because you just kind of judge, but if you have somebody who is healthy and a good, good shape, and then just really you don't find anything, and somebody young. I remember this guy for head and neck. And then it's like, you're doing great. He was going to the gym all the time. He was a runner on his kind of 30s. It's like, you all do great. I more likely will see you towards the end of radiation. I don't think you need to see me.
And probably just for like a check-in, you're probably thinking, right?
Exactly. Yeah. And then here he comes, like around that time, because that's the time we got, and he lost so much weight because unfortunately he got hit with COVID and pneumonia, and then all the side effects. And I was like, so like regretted that, why didn't I say without thinking, because you're young and you're healthy and you're going to be just fine, just really not see him halfway through where I feel like I couldn't create more impact on his recovery without knowing all these things he was going to go through.
Yeah.
So I kind of stopped myself saying that now, no matter
Yeah.
how good
Now we
shape you
usually
are
do
now,
the midway.
and then we're just going to try to do midway no matter what. If they come midway
Or
and
2
they're
weeks
doing
sometimes,
great,
they'll do 2 weeks,
exactly.
yeah.
And if they're doing great, then that's awesome. But then it's kind of sometimes we just thinking what somebody's gonna
Yeah,
do with these treatments, and perhaps, you don't
Yeah.
know what's gonna happen.
right, exactly.
So
Yeah, that's good. I was gonna say the other challenge I think we have with them is scheduling.
Yep.
Just because it's a patient population that has so many appointments. And at UF Health, a lot of the patients are out of town. So it's also that dilemma of them having to drive to, get to us on a day. Maybe they didn't have any other appointments. They're just coming to PT, even though we do try to schedule on days that with other patients. So that is another challenge with this population because they truly have so many other appointments.
Yep, absolutely. And they get
So
overwhelmed.
scheduling.
Yep, and they get so overwhelmed.
Mhm.
How do you approach working with patients who may feel discouraged or overwhelmed with their diagnosis?
Yes, so this is probably, I should have mentioned earlier, we should have talked a little bit about, this is also probably one of the things that might keep a therapist from working with an oncology patient because it's intimidating to think you're working with someone who's going through a diagnosis like that. I mean, there are other PT specialties that also go through that, the movement disorders, even like a post-stroke. I mean, there's so many that have to deal with that emotional side of things. So this is that same circumstance, and that can feel intimidating, but I truly feel, and I think it's something our team is really good at, just listening and showing good empathy and letting them know you are there for them and you are hearing what they are saying, but then giving them the confidence that you can still do this program. And you're right, it's going to suck during this part, but as long as we keep doing this and we're here with you, we're behind you, and your family members are behind you, and whoever comes with you, we always talk about support system, you're going to get through this. So that is definitely an aspect with these patients, but it's actually one of the aspects I really enjoy because these patients are so cool. Like they just are going through so much, and we've met just like the most amazing people, patient-wise. And to see them go through these ups and downs and then come out at the end, just like these amazing people in this journey they've been through. I don't know. It's just one of the things I actually really love about it. I mean, it breaks my heart to see when they are in the downs, but I love that we get to be there for them for that.
Yeah, absolutely.
And they do talk about that. They do say, I mean, I really am so thankful for, that part of it too, that you didn't just ignore that part and say, well, yeah, I get, that's all going on, but come on, 10 more.
Yeah, 10 more.
10 more exercises on that foam roll. Come on.
Exactly.
So I do think you have to have an element in yourself as a therapist and a person that is a part that you do need to take the time sometimes and listen, work through some of that. And then that is a skill set as well, then that the students have to learn to be able to do that at the same time, redirecting and maybe working into some of your exercise program while you're still but never making them feel like that is that you're not listening to those concerns.
Exactly. Now, that was another, now that you mentioned that, is because we have the opportunity, sorry, here is Luca, like
the puppies here.
Really see it. But we have a great opportunity because we see these patients pre-op. Actually, that happened to us yesterday. To us, I have a couple of students with me now, have these patients who, they usually go for surgery, right? Or they start in surgery with breast cancer and then come to us for pre-op. And this patient had an appointment with medical oncology, and she really didn't want to have a mastectomy. But that's what the surgeon recommended. But when she went to medical oncology, because the stage that she's at is like, well, I really want to, I want to conserve my breast. I want to do just a lumpectomy. So the options for her was either, if we want to do that, we may have to do like a neoadjuvant chemo, meaning chemotherapy before surgery, in order for us to do that. She thought, but she has to be in an endocrine therapy as well. So she really was convinced that just having the endocrine therapy or the hormone blockers was just going to be the chemotherapy that she was going to need to be able to have a segmental mastectomy or lumpectomy. She had like absolutely no idea that wasn't the case. So here is one of our role is just because we spend this much time with the patient and the patient is so overwhelmed, right? Within 2 weeks, she went from an appointment with the surgeon, who is amazing, but it's a lot of information, and then goes from there to the medical oncology, which is great, but it's all this information about, this is the percentage of survival. This is the percentage if you do ABC. This is what you can do, work, all that.
And then the surgeons, because she's so fantastic and so thorough, she's ordering more imaging and
Exactly.
and maybe genetics.
And that's exactly her situation.
So in those 2 weeks, these patients see so many people and get so much information.
So this is the husband with the wife, and they were like absolutely no idea what was coming down. And then I was like, no, this is endocrine therapy. If you're really looking into doing this, I know that we were depending on an MRI and another test, but really, you now have to really wait for the MRI, and then I have to really sit down with them half an hour and explain to them, this is so many different type of therapy.
Yeah.
This is what it is, this is what it is, this is what it is. But of course, we have a nurse navigator, and that's part of her role. It's like, when you have all your testing done, I want you to reach out to our nurse navigator, which I sent her a message as well, saying these patients need an extra visit with you, because they're like absolutely don't understand what is the process. But it's amazing how they're like totally lost, and how they just think that they understand something. And again, because as we just throw even ourselves many times so much new information, that this is people who is not in the healthcare system. They absolutely don't have an idea, besides the word cancer is the only thing is on their head. And she's like, I just want to get over with this. And it's like, you are not going to get over with this if you're thinking to go through chemotherapy to conserve your breast, if that's what you want to do. And so she's like, oh my God, I didn't realize what all this entailed. It's like, I understand that, but it's amazing. So you really, if you want to be doing oncology, again, you have to be full of knowledge in what is all this treatment means, and how is this whole process, right? Because it's not just, oh yeah, maybe it's this medication is creating, nausea and vomiting, and you're like, well, what is this medication? And the patient is thinking it's one thing, no, it cannot be that thing. That's just really,
that doesn't cause that.
Doesn't cause that. So what else is happening? So really, you just have to have a little bit more knowledge about what this cancer treatment.
Which again, like you said in the beginning, we were like, what are they saying in tumor board? But then
exactly.
You just learn and you read, and what we are very fortunate is that we have such an amazing medical team that just totally values rehab, and like you being able to reach out to the nurse navigator. I mean, we're just so blessed and fortunate to have that communication circle with our practitioners.
What advice would you give to a cancer patient who may be hesitant about physical therapy?
Yes, well, we would just go through all those things. That these are the things that could go on side effect wise, but these are the things that we would do in physical therapy to help that. And we're pretty honest in the beginning, saying, yeah, these are the things that are going to happen. Like it's not like, say, a post-op, orthopedic surgery where each week they're getting better. Like, we're telling them to expect to get a little worse or stay the same during chemo, radiation. Each week might be worse and worse. Like, that is expected, and that is going to be okay. So just talking them through that, and I think I think as much knowledge as they can have before, even if it's overwhelming, we just keep talking about it. When they're ready to receive more, we just talk about it again. It's okay. We repeat ourselves a lot, and we're okay with that. Just letting them know that it's okay, and we're there to help support them and get them through that.
Yep. Yeah, that's perfect. Yeah, sometimes, you have situations with just make me remind another patient that, again, head and neck were doing really well. And like, I really don't know. I just have this little thing here that is more swelling after my neck surgery, but I'm doing fantastic. I have a farm. I'm already doing ABC.
Yeah.
I really need to be here. I think this is a joke. I mean, he was really having the attitude. And I understand, it's like, I think this is, again, a waste of time. They live 2 hours away. And his significant other, I think, is like girlfriend. She was like on top of being like, she totally clear, understand the risk of lymphedema after, head and neck, lymph nodes being removed. So we showed them a couple of things to start to work on, and they just came back again yesterday, actually, like 4 weeks, because they have another appointment with the doctor. And then she's like, no, we've been doing this MLD, we're doing this. And he was all in tune with it. It's like, yeah, do you have anything else that you want me to do? Like totally a different person.
Yeah.
And how his attitude was when he came in the beginning. It's
Yeah.
like, I really have no idea what I'm doing here. And we were just doing battles. And he's like, are we done? Can I go now? And
Yeah.
then he's like, no, we're just at the beginning of this, right? So again, it's just kind of explained to patients and they really appreciate the education and the reinforced education that they've been hearing before. But again, because it's so much information, we can really break it out and maybe reinforce that little by little as we have a little bit more closer relationship with them, because we spend one-on-one with them longer time than what the physicians can do.
Yes, and the patients say that a lot too. Like, it's so nice that we have more time with you. We can, ask questions.
What advancement in cancer rehabilitation are the most excited about? What are you most excited about?
I'm really excited about the lymphatic anatomy work that Dr. Drew Singhal is doing.
You want to tell
He's
the audience
amazing. We love him. Oh, he talked about it?
Yeah, like, you want to tell the audience about it?
Yeah, I mean, that's just exactly what he's doing. He's literally remapping the lymphatic system with the newer technology that is available now. And if you ever get a chance to listen to, I know Darley did a podcast with him, so that's great. But if you ever got a chance to listen to a lecture of his, any of his lectures are phenomenal, because he is one of the most passionate people I've ever met and come across, and he's so passionate. But when he talks about the lymphatic anatomy and remapping it and then finding new connections and channels, and I mean, as a lymphedema therapist who in the beginning, in the early 2000s, was told this is the only way to do MLD, it's the only way lymph fluid moves, and now we're just learning so much more about the connections between superficial and deep, and bundles that are coming out the lateral arm, and even at the National Lymphedema Network, I listened to the digital conference in October. They're now talking about the brain lymphatics and the lymphedema surgeons going ahead and seeing, can they affect things like patients with migraines? Can they affect Alzheimer's? So I think that is like really just awesome, amazing, cool stuff. So lymphatic anatomy, for a long time, we're very hopeful that eventually in human trials, we'll see the increased chemo benefit of a patient who exercises and gets their heart rate up right before they get the chemo. There are mice studies that show that, and I know human trials are hopefully on the horizon for that or in their initial state. So that would be really exciting in terms of exercise prescription and helping the chemotherapy be more effective. Yeah, I mean, that is crazy because I feel like there really is so much happening on the medical side and then on the rehab side. So
yeah, absolutely. And with that, what I really think I'm very excited about.
Good notes. Let me see if I have anything else. But go ahead.
Something that we've been doing is Australia start doing some work again, all these lymphatic anatomy. Luke. Sorry, my dog is just kind of here, kind of biased. But Luca. Anyway, so we have Australians are doing some really good work about this lymphatic mapping and start to discover that we know Shannon and I are lymphedema therapist certified. And when we learn through, the different schools who certify you as a lymphedema therapist is these paths of drainage. And now all this has changed so much, right? Because when we thought was happening in anatomy, it's not what really is happening.
Yeah.
So now we do this mapping that in Australia, and now Dr. Singhal at Israel, they're doing MLD, which is manual lymphatic drainage, utilizing ICG. So they're able to actually see what the flow is happening, and you can actually do an MLD as you're looking at the images. So you can actually see,
like, if there's a blockage here, where's the blockage? And then as you're doing the manual lymph drainage, you see, is the lymph moving? Is it not moving?
Exactly.
What if I go to the anterior arm and move? I mean, so to be able to eventually do that in the clinic live would be amazing.
Yeah, which is happening because in Israel, they're already doing it, and it is amazing.
I meant for us to be doing that. That'd be amazing.
Yeah,
I know they're doing it elsewhere.
Exactly. So for us, that's our aim. That's what we love to do. Hopefully, at one point.
But a newer thing too for us is on that same lines. That is wonderful. Is Dr. Spiegel, our breast surgeon, is providing a still shot map of that patient's healthy lymphatics before the surgery. And then that is helping us guide what drainage pattern we teach them after the surgery for lymph movement. So that is actually something very new that is happening. That is wonderful as well.
Exactly.
To more personalize
Exactly.
the manual lymph drainage sequence for each patient.
And so we're doing a trial based on that right now, where it's called an MLD trial that is being done right now. We just started recruiting like a couple of months ago, where we're looking at is the traditional MLD, which traditional manual lymphatic drainage is, what kind of effects are we going to have with this lymphedema versus using that mapping specific for that patient. So we're doing a randomized trial with that right now. So stay tuned. Hopefully in a year we will see
maybe
results.
episode 200.
Exactly. Hopefully, yeah, that's right. So we will gonna kind of bring Dr. Spiegel back again, since she was one of my first kind of episode pioneer to try to talk about this. But I think that it is exciting. It's exciting that we see how much more we can be so individualized and personalized treatment. So it's not just the cancer and it is not just the surgery, but as well our treatments treating these patients. Is anything else that you're excited about it before we move on?
Is there something I'm forgetting? I had written some little notes.
Yeah, sure.
Yes, the lymphedema anatomy, the brain lymphatics, that was super cool. Our work with Dr. Spiegel and the mapping, exercise, chemo. Yeah, those are the things I had written down.
Yeah, we have one thing as well that I'm really getting really excited. Oh, I've been very excited about it, but has been more lately. We start before COVID was a research done at UF with mice in regarding how exercise can improve the enhancement of chemotherapy and radiation therapy. So if we what they did just started with mice where they exercise them. And then the guys that were on treadmills, you increase the oxygen to the cancer cell, and then the chemotherapy or radiation that is going to happen to that has increased the efficacy of it. So the treatments are so much better. So when I heard that, I was like, oh my God, we got to do this in humans with us. We need to do this in our patients, but unfortunately COVID showed up and this didn't happen at UF. But I know has been some research going somewhere else. I think I don't remember exactly where now.
That's, I mean, I think they're in the first year of the human trials. Right?
Exactly. And the only thing I can tell you, I don't know if this chemotherapy enhancement is more efficient or not on these patients, but I can tell you how less secondary effects these patients who are doing this. And this means they actually exercise hard on a high intensity, it's a HIIT program, high interval training prior to chemo and prior to radiation, and their side effects are really had improved so much. So I see this day in and day out. We used to do it sporadically. Now we've seen more and more. And I hope that was kind of a standard of care. That's what I'm hoping for us to be able to do, at least with our.
I mean, we've even talked about infusion, being able to get like bicycles in there or just something that keeps that heart rate up and hopefully continues to have that effect while they're receiving the chemo.
Yeah, exactly. So that's, hopefully we can start seeing some of that more research, and hopefully more centers, including ours, start to really be like a standard of care, not just sporadically happening. So I think that will be really excited to see.
Yes.
What role does exercise play in cancer prevention and survivorship?
Yes. So, I mean, the American Cancer Society puts out guidelines because there is very strong literature supporting exercise is necessary to prevent cancer. I mean, I think it's across the board, almost all cancers, some, not like some of the organ cancers. I don't know if I do not believe it affects that, but the majority of the cancers, exercise is so important. So their guidelines are 150 to 300 minutes per week of moderate exercise, or 75 to 150 minutes per week of vigorous exercise, or some kind of combination of that. So it's getting your heart rate up. Moderate exercise is getting your heart rate up so you can still talk to someone, but you're feeling it. But maybe I think their description is you can't sing. You can talk, but you can't sing. And then vigorous exercise is where you really are actually having a hard time talking. You're they describe it as like huffing, puffing, but you're elevating that intensity. And then even with our patients who have already had cancer, so one population we work with specifically is the estrogen positive breast cancer patient, and the medical oncologists do discuss this with them. They have over a 30% greater recurrence rate once they're done with all their treatments if they have a higher BMI, so BMI of 29 or above. So we take that very seriously when we talk with the patients. We have bioimpedance units at the clinic that allow us to not only monitor and assess for fluid in the limb while we're watching for lymphedema, but also body composition. So it lets us have a real conversation with the patient about their weight, their body mass, the BMI number that needs to come down, and then skeletal muscle mass if we're watching any muscle loss during chemo. But it really allows that conversation to open up about extra changes with their exercise program, changes in their food plan daily, their hydration levels, things like that. And they're very receptive to it because, they'll say things like, oh, my doctor's been telling me I lose weight forever. But when they're now told you have a 30% chance of your cancer coming back, you've just gone through all of this if you don't get that number down. And then they are like,
Yeah.
okay,
Yeah.
I'm ready for this now. So that is actually, again, one of those things where they really need to be looked at as a more chronic long-term patient, not just, oh, you're done with treatments.
Exactly.
So yes, so it's very important for survivorship, and then it's very important for prevention.
Yeah. Actually, talking with Dr. Spiegel a couple of weeks ago, she was talking with Dr. Singhol, and he was, what they're doing now up there, they actually, patients who have high BMI, they've been sending to the clinic for obesity when they're looking into GLP-1. And what he's been noticing, again, I'm not super fan of it because we know how much skeletal muscle mass you can lose with these medications.
Yeah, they're saying that.
But yeah, you just have to monitor, right? But he was saying how his patients who had lymphedema, putting in that really improved their lymphedema because they're losing the weight.
Yes, because you're at a higher risk for developing lymphedema if you also have a BMI of 29 or
exactly. So we were having a discussions about, and of course for her, everything is let's do a trial, let's write a paper, because we were talking about how, and I gave them a lecture at the Lymphedema Symposium a few years back, and my lecture was about lymphedema risk and actually BMI.
And that's right, I remember that.
Yes, and how we were like talking about like maybe we shouldn't be talking so much about BMI, but talking more about how much actually fat mass versus skeletal muscle mass, right? Because you can have somebody who has a BMI of 29 or 27, 29, but what if it's like most of it is muscle, and then it's a little bit of fat. So we just really judging on the BMI versus skeletal muscle mass.
And I do talk to them about that because I've always loved that lecture of yours. I just do that. I tell them the medical oncologists talk about the BMI just because that is what the literature is based off at the time, but that is truly what we want to get down. Is that body fat mass.
Exactly. So again, super excited, but we really, that is a good motivation when we do this body composition regarding patients, try to really get things like exercise is so important, not just necessarily to decrease that, but as well all the endocrine therapy and the deplete of estrogen when that's to the bones, and how exercise can improve that as well. Prevent osteopenia and the fracture risk later on. So it's really one changes drop to the other, right? So we try to really do that.
So that is actually, the more we talk about that and we see protocols change with that, some new stuff in cancer. It's not new in cancer rehab, but that continued exercise prescription adjustment and like the support for that.
Exactly. So would you like me to refine, is anything else you want me to add before we wrap up? I know we talk a lot.
No, I know. Everyone's going to be bored with our conversation. I mean, we could talk about this stuff all day.
Yes.
No, I mean, I'm just thank you for having me. I feel honored to be your 100.
Oh, that's amazing.
It's a big deal because I'm not really great with these things. So I would only do this for her.
I know she will.
Even though in the clinic I could talk like literally
she hates
all day.
To speak in public.
But even though I'm a huge talker in the clinic, but so I wanted to do this for her because I'm so proud of you.
Oh, thank you.
And I just feel so blessed that you walked into my life those years ago.
That's awesome. So Shannon, cheers again for
Cheers to you.
hopefully we'll see you in the 200 chapters talking about all the updates that we are gonna be doing at that point. So thank you again for listening, and you guys have a good night.